We probably have more people as we start, but my name is Henry Ann Westberg, and I am on the Speaker Series Program Committee. And back in August, I saw this article about the gist of it just says that the Idaho Department of Health and Welfare had signed a $1.2 billion contract with Magellan Health to manage and deliver behavioral health and substance abuse treatment in our state. And so today, I'm very happy that we have someone who can walk us through this particular change. And I want to thank the county commissioners because Tom Lamar and Kathy LaFortune were good enough to put me in contact with our local behavioral health district person, who put me in touch with David Tover, who is the bureau chief for the Idaho Behavioral Health Program. And then he sent out an email to see who on his staff might be available or interested. And thank goodness, we were lucky enough to have Christina Ward answer that request. And so I thank her so much because I know she is very busy. And she will have Carla Burleson helping her today. They're going to tag team with, they have 2 slideshows to share with us. And so Christina is a licensed clinical professional counselor, and she's been a licensed clinician in Florida for 20 years. And then she has worked at the Department of Health and Welfare as the program manager for the Analytics and Automation Unit, and currently is the program manager for the Quality and Clinical Unit in the Idaho Behavioral Health Program Governance Bureau. That's quite a handle. So she has previously been the executive director of Recovery Ways Idaho, where she worked to expand services that were offered to include substance use disorder and intensive outpatient programs. So without taking any more time from her, a big welcome for Christina Ward, and I will let you get started. Thanks for being here.
Thank you so much. I appreciate that. And I did want to just make a correction. So David Tovar since is no longer with the department. He actually he actually took a role with Magellan. He is the director of network. And so we do have a new bureau chief at the IBHP Bureau, and it's Adam Panich, who has been with the department for many, many years, working for the Division of Behavioral Health. So I just wanted to let you know that.
Thank you.
All right, and I think my slides are going to be shared, correct? There we go. And so what I thought I would do today is really just give a very high-level overview of the changes that will be happening with this new IBHP contract, and kind of just let you know how our bureau is set up, how we are functioning, how we are working on this current implementation, what's going to be changing. And I will answer any questions that you might have. And if it's a question I'm not able to answer, I will take it back to my team and we'll be sure to get back to you. I also put in the chat an email address that is manned by our bureau, so that if you have any questions related to the new contract, you're more than welcome to send those questions to that email, which is ibhp@dhw.idaho.gov. All right, our bureau is called the Idaho Behavioral Health Plan Governance Bureau. Next slide, please. And I'm going to move my... Okay. The vision for this bureau, it's something very unique that Idaho has never done before. This bureau is really combining the Division of Behavioral Health and Division of Medicaid. And we are bringing those 2 divisions together so that we could have remain engaged and leverage the expertise of each of the divisions and what they bring to the table, because this new contract will be serving both Medicaid members as well as non-Medicaid members. So we need those subject matter experts from both the Division of Behavioral Health and Division of Medicaid. So as I start talking to you about all these meetings that we're having in preparing for this implementation and go live, we are making sure that we have the right people at the table at these meetings when we're making these decisions moving forward, so that we are really thinking about how DBH, Division of Behavioral Health, works, and how the Division of Medicaid works, and all the constraints that they have to follow based on their guidelines, state statutes, legislation, and et cetera. Next slide. So under the new IBHP Bureau, as I said, we have the Bureau Chief, who's Adam Panich, and then we have 3 teams that fall under our Bureau that have 3 main functions. So the first one is our contract operations. So this is the governance of the IBHP through accountability, participation, predictability, and transparency. And what that means is this team are making sure that Magellan is following what is written in their contract. So the state holds the contract with Magellan, and this team will ensure that they are meeting their contractual obligations to the state. And that team is led by Ashley Porter, who has been with Medicaid for many years. So she's very knowledgeable of Medicaid. And she has a team of 5 that are working under her and to ensure that they're following the contract. Then you have the second team, which is clinical and quality, and that's the team that I have. And we are the oversight of the quality, performance, and system innovation. So I have 3 members under my team. I have a member or an employee who's dedicated to quality. So she will be working with Magellan to ensure that quality services are being provided, any quality initiatives that we have, all of those quality improvement projects that we'll be working on. She will be a key role in those projects. And then I have an employee that's dedicated to adult behavioral health. So that includes mental health and SUD, which is substance use disorder. And then I have an employee who will be dedicated to children's behavioral health. And that includes, again, mental health and substance use disorders. Then we have a third team, which is contract. Oh, I'm sorry. I said monitoring for the first one. It should have been operations. I apologize. The third team is contract operations. So this team is managed by Mallory Kotze, who comes from Medicaid as well. And she's currently has been managing the current IBHP contract with Optum for the last 6 years. So she's very knowledgeable with managing these contracts. And so she has a team of 5 as well that ensures the contract operations day to day, handles any issues or concerns that are going on within implementing that contract. All right, next slide. So what's changing? So currently within the Division of Behavioral Health, this is kind of a org chart of what is currently existing within DBH. We have our division administrator, which is Ross Edmonds, and we have our deputy administrator, which is Jamie Teeter. We have the medical director, state hospitals, right? And we have a quality team, the QMIA team. There is the State Hospital North, State Hospital South, and State Hospital West that follows under the Division of Behavioral Health. And then you have different bureaus that we have that are currently under the Division of Behavioral Health. You have your Oversight and Statewide Operations Bureau, which really is managing everything that happens within the state of Idaho. And they have a training and communications team. They have an analytics and automation team, which is where I came from. They have a contracts team. They have a fiscal team, and then they have a compliance and policy team. Then you have the Clinical Services Bureau, which currently a lot of the Clinical Services Bureau staff are providing direct services. So these are the ones that are doing the designated examinations for folks that are committed into hospitals. And so they do some direct services as well within the regions. And then we have our strategy innovation and community development bureau, our center of excellence bureau, and then the Idaho behavioral health plan. So this just kind of shows you how the division of behavioral health is the org chart and how it's created. And you'll see that the Idaho Behavioral Health Plan Governance Bureau falls within the division of behavioral health, but also within the division of Medicaid. Next slide. So currently, as I said, the Division of Behavioral Health operates the involuntary treatment system. So the court-ordered evaluations, the designated examinations, they look at pre and post commitment processes, and there are the gateway to the state hospital admissions discharges. Now, with the new IBHP, they will continue to be involved with the court-ordered evaluations and designated examinations. So the Division of Behavioral Health will continue to do that, and they will continue to manage the state hospitals. But as you can imagine, Magellan is going to need to be very involved in that process, right? Because they're going to be managing outpatient and inpatient services. So there'll need to be that collaboration between the new IBHP and the DBH folks that are doing these services. And DBH is also the state behavioral health authority. So they will continue to have that quality management and oversight. They have the Center of Excellence, which is what COE stands for. And Center of Excellence is a new bureau that was created that really looks at services that have evidence-based models to them, that have high fidelity models. And what that means is these services have been researched and been shown through research to be very effective in treating the population that it was designed to treat. And so the COE will continue to provide training and support to providers who will be delivering these high fidelity services, but we want someone to be there to make sure that the services are being provided to the level they need to be. And I know this is a lot of clinical terms, so if anybody has questions, we can wait till the end, and I'll be more than happy to expand on that. They will promote the standard that guides essential functions of service delivery and qualification. So that's our policy and compliance within the DBH. They'll ensure that providers are following any of the policies that have been established within the state of Idaho and making sure that the standards are being met. And then behavioral health system monitoring. Next slide. So within Medicaid, there's a few things that are currently being managed by Medicaid that are being transitioned over to the new IBHP Governance Bureau. And one of them is the management over the 1115 waiver. And the goals of this waiver include increased access to and availability of care, expanded coverage of Medicaid services, and improved care coordinations and transitions between levels of care. So whereas Medicaid used to be over this waiver, it is now being transitioned into our bureau. And Ashley Porter's team, who is the contract monitoring team, is taking the lead on managing this waiver. And it's just ensuring that under the waiver, the folks that are entitled to get the services they're entitled to get will be getting those services, and monitoring that to ensure the availability and that they're getting those services. And then also management over the Penn State contract, which is an external contract that we have that monitors and ensures that we are following the 1115 waiver and managing it the way that it needs to be managed. So it's kind of like an external review of that process. And then the IBHP management, so management over the current IBHP. So right now with Optum, they only manage outpatient behavioral health services. And so because we still have a contract with Optum until the new IBHP takes over, our bureau is working with Optum and managing their current contract. where it used to be with just Medicaid, but now it's with our bureau, which is the combination of Division of Behavioral Health and Medicaid. And then the youth empowerment services, which are our YES services, they are now being managed under our bureau as well. The 1915I State Plan Amendment, which is what SPA stands for, and the Medicaid YES program. Next slide. So within this contract, there are several partners that are listed in the contract that we have for the new IBHP. And the Idaho Department of Juvenile Corrections is a partner that we're working very closely with, and their key players have been at all the meetings that we have with Magellan, so they have been a big part of this implementation. As I mentioned, Division of Medicaid is another partner, Division of Behavioral Health, and then Magellan. And then, of course, in the center of that is the participant or the member, because that's the most important person in this whole process. Next slide. So the current IBHP to the new IBHP. So the current IBHP plan that we have, it offered a variety of outpatient behavioral health services to Medicaid members in Idaho. The new contract has expanded this scope because it includes not only outpatient, but also inpatient behavioral health services. So this is really, so now it's all going to be under one umbrella, right? Whereas before it was kind of managed piecemeal with different folks, but now inpatient and outpatient is all going to be under the new contract. And some advantages to that is continuity of care, right? So now it's going to be managed by just one entity, so that they will be able to ensure that as someone is stepping out of a state hospital or someone is stepping out of an inpatient facility, that they can have services in place for their discharge and follow that member to ensure that it's a smooth transition, right, from that one level of care to the next, and that they're getting the services that they need to be able to stay out of those higher levels of care. It'll minimize disruption to operations of providers, and it will ensure community stakeholders are well informed. And we already talked about the continuity of care for the patient. Next slide. When we first started having our discussions, we had a kickoff back in July of last year with Magellan, and we really needed to decide how are we going to move forward with this huge implementation. As you can imagine, it's very large. And so we identified 4 main work streams where we would have ongoing meetings around these work stream topics, and it helped us to make sure that we could identify who the subject matter experts were for each of the divisions to ensure that all the right people were at the table when we were making these decisions and working through this implementation. So clinical, financial, network, and technical were the 4 main work streams that we identified. Next slide. And this breaks down some of the topics that we discuss at each of these meetings. So under clinical, you've got clinical operations, you've got our crisis system of care, which is huge, recovery, resilience, member outreach, quality, training, and a member transition plan. So those are all the main topics that we address within that clinical workstream meeting. Financial, it's the finance and braided funding, as you can imagine, because we are dealing with both Medicaid and non-Medicaid members, right? There's funding coming from different streams. So you have Medicaid funding, and then you have on the Division of Behavioral Health side, a lot of their funding comes from the Mental Health Block Grant, the Substance Use Block Grant, and other funding sources. So we needed to ensure that Magellan was clear on what services are funded by which funding stream and what that looks like. Then we have network, and network includes building that network for providers in the community, tribal relations, and then marketing and communications. And then within the technical side, claims And then Magellan has their own technical platforms and what that looks like and how it will be integrated and how providers will get training and what does that look like. So those are some of the topics we discuss in those meetings. Next slide. And this last slide basically is this go live service date. So go live is now 7/1 of this year. That date was extended from the original March 1st because we wanted to ensure plenty of time to make this transition and implementation a seamless one for all. So that's the end of my presentation. Again, just a very high level overview. And so does anybody have any questions?
Could you explain the 1115 waiver? I've never heard of that.
I am not the expert on that. So
Okay. Ashley is.
Yeah, Ashley is. So I can
Oh, that's okay.
get some information, see if she has maybe just or if there's a website. There might be a website that explains it. So I can go, find that out for you and get that to you.
Have you included insurance companies? Because I know you're working with both insured, non-insured, and Medicaid patients.
What type of insurance companies are you?
Well, like if you have Blue Cross of Idaho and or any of the private insured people that have a mental illness that need treatment.
So for this contract, it is just, we've worked with Magellan to identify if they have other payers, or other insurance and what that looks like in terms of billing. So we have walked through what that looks like because we know that there will be folks that might come with other insurance. So there is a procedure or policy in place for what that would look like. And so we are currently reviewing the provider manual that Magellan will be sending out, right? And so that will have information about that in there for providers. It's currently under review with the state. So once we have an opportunity to review that and send back any feedback, and once it's finalized, then that will be available for providers. And I think that will answer a lot of questions that providers have specifically related to billing and claims and reimbursement rates and things like that.
The other question I had was, you mentioned inpatient and outpatient, and St. Joe's used to have an outpatient in Lewiston, and currently in Moscow, I don't know if we have any outpatient mental health clinics. So have you studied the state to see which areas need added resources?
That is part of Magellan's, kind of developing the network adequacy. So they are working very closely with providers. They've had meetings with the Hospital Association here in Idaho. So I'm trying to identify what areas are, we need more providers in. So yes, they are having those meetings and discussions and evaluating that as part of the implementation.
Yeah, because if you're going to follow up with someone after they get out of State Hospital North up here, that's almost going to be a necessity to have some type of outpatient clinic or resources available to help monitor people and whether they're taking their meds, going to counseling, doing what the treatment plan says. So. Okay, thanks. Does anybody else have questions, or is there anything in the chat? Feel free to use the chat.
Any of this apply to CPS mandated health services? I'm just going to say that I am new to Idaho. I've only been here for 2 years, so I'm still learning all of this. Is that like child protection services? So is that like the facts team? Is that what you're talking about, Sharon?
Yes, I think that is.
So there may be some overlap with, right? Some of the kids that are in facts, there might be some overlap with services. So we have been having conversations with facts and other folks, so I'm not sure if I'm understanding your question.
What I'm talking about is funding for people in the CPS system, primarily parents who have a case plan and they're required to seek mental health services. And if they make too much money to be on Medicaid, is there something in this plan that can help them get services? Do you even have something in this plan that applies to CPS?
Yeah, I don't think we do. But I will, if the contract is over 900 pages long, and I don't recall that that is something in it, but let me take it back and verify that.
What is the role of the Idaho Behavioral Health Program as far as providing services to people in the CPS system?
Sure. So the IBHP contract, they do not provide any direct services. There might be some admin services they do, like some coordination, intensive coordination and things like that. But most of the IBHP contract, Magellan will be contracting with providers out in the community to deliver the services. And so they would be just managing the contract with those providers. So they're not going to be doing a lot of direct services. They're going to be looking to providers out in the community to do that.
Okay, thank you.
Yeah, you're welcome. And I think I can provide a copy of the slides. I will just verify that. I don't know why you couldn't, because you saw them. So, but let me just verify that.
Thank you.
And if you guys think of other questions, like I said, feel free to email them to that inbox that I put in the chat, the ibhp@dhw.idaho.gov. I can put it in the chat again, because I know sometimes if you join after I post it, you may not see it. So there it is again.
Oh,
And I hope that what I provided is what you were looking for. But
I think the overview is great. Yeah.
okay, perfect. Okay.
It's
Well,
a lot. It's a lot to soak in.
yeah, I think the main difference is really understanding that whereas the current contract only covers outpatient services and only covers Medicaid members, the new contract is going to be Medicaid and non-Medicaid and outpatient and inpatient. I mean, that's the big difference. But that means a lot. Like there's so much involved in that difference, but I think that's the main difference. And providers will be now contracting with a different MCO, managed care organization, right, to provide those services. But there's a lot of partnership and a lot of support that will be ensuring this implementation happens. So I think that's nice too. So yeah.
Okay. Thank you. Would you like to introduce your next presenter, and we can start learning more about ACT.
Sure. So Carla Burleson, I'm going to let you kind of just provide your background, but she is a human program specialist with the ACT, with the COE, correct, Carla? And yeah, so she's kind of had to step in. Monica was going to be here, but Monica couldn't be here today. So if you want to just provide a little bit about your background and your position within the COE, and I'll let you take it from there.
Yeah, absolutely. Hello, everyone. I'm Carla Burleson, and I'm, like Christina said, I am a program specialist with the Center of Excellence, specializing in ACT teams. And I know you were expecting Monica Martin, and I'm really sorry about that because she's amazing. But unfortunately, like Christina said, she was unable to be here. So I was given the opportunity to fill in for her, and I'm really happy to be here. So just to tell you a little bit about myself, I have worked for the Department of Health and Welfare for 22 years, with 16 of those being in the Division of Behavioral Health. I've worked on just about every team within adult mental health. Haven't worked with children's mental health. And I've spent the majority of my career working with ACT and mental health court teams. So I must say ACT teams are definitely my first love. So can we start my slides? There we go. Okay. So I'm just going to talk with you today about the new Center of Excellence and specifically ACT teams that we will be standing up in communities around the state later this year. So let me start by giving you just a little bit of history. Prior to Medicaid expansion in 2020, the Department of Health and Welfare's Division of Behavioral Health provided behavioral health services for people who either had no insurance or were underinsured. Before Medicaid expansion, in order to qualify for Medicaid, a person had to be on Social Security disability. So as you can imagine, that left a lot of people without coverage. But once Medicaid expansion rolled out, a majority of those folks were able to receive services from community agencies, which is great. So many people have been able to get mental health treatment that were unable to afford it prior to Medicaid expansion. But there still, however, is a gap with certain services that the Center of Excellence will be working with community agencies to fill. So as you can see here, the Center of Excellence is made up of 6 competency centers. Each competency center is made up of a team of trained and certified subject matter experts who will work collaboratively with community agencies across the state, providing training, coaching, technical assistance, as well as fidelity reviews for each of these specialized centers. So I'm going to go over each one of these just very briefly. Now, the thing to remember is, though, that these are services that the department has historically provided, and the COE will be working with community agencies to stand up their own teams. So first we have ACT and Mental Health Court, and I will expand on that in just a couple of minutes, but ACT stands for Assertive Community Treatment, and ACT is an evidence-based model that utilizes a team-based approach to provide a range of intensive outpatient services that are community-based. ESMI stands for Early Serious Mental Illness. ESMI teams serve clients in that 15 to 30 age range. So these are clients that have had their first episode of psychosis in the past 2 years. Mobile crisis teams will respond to individuals in the community experiencing a mental health crisis. Sometimes these calls are made in conjunction with law enforcement, but their goal is really to stabilize folks in the community. Then we have PLL, which is Parenting with Love and Limits. This is an evidence-based family-focused intervention and treatment program. Next, we have TCOM or CANS. Now, this one is a mouthful. TCOM stands for Transformation Collaborative Outcome Management. Say that 3 times fast. TCOM uses a consensus-based assessment approach. In a nutshell, TCOM is an assessment for kids to identify needs using a variety of tools, and CANS is actually one of those tools. Then lastly, we have Wraparound. And Wraparound is intended to assist families who may be experiencing high levels of need or who are at risk of more intensive services, including out-of-home placement. So this is just a brief overview of the 6 different competency centers, but I'm actually here to talk more about ACT. Next slide, please. ACT is an evidence-based model and is designed to provide all of the services a client would need through one team. The team approach is a big piece of the model and requires a transdisciplinary approach. Now, what that means is that each role understands everyone else's roles and can bridge between each other. ACT teams have daily team meetings to ensure that the intensive outpatient services are synchronized and organized, with handoffs between each team member. Most importantly, the client is the focus of ACT, helping the client regain their voice from the institutions that they likely have been a part of and helping the client find their intrinsic reasons for recovery. In ACT, there used to be a well-known phrase of ACT for life, or once you're on ACT, you're always on ACT. This is the concept that you remain an ACT client long-term to maintain your recovery. I can tell you that when I worked on ACT teams, we had clients that had been ACT clients for 15 or so years. So it really was the culture at that time. With ACT in Idaho, however, we are updating our ACT beliefs and core values and aligning with the innovations that have happened with the model. We will be training to a graduation track for ACT rather than ACT for life, which instills hope and long-term recovery options for clients. Also important is we understand that ACT is mostly rural. Many of us at the Center of Excellence have practiced ACT in rural Idaho. So just know that there will be considerations for Idaho and our ruralness with the model. Now, what that's going to look like exactly is still being determined, but just know there will be adjustments to that. Next slide, please. So who does ACT serve? Well, ACT serves adults with a severe and persistent mental illness, or SPMI, as we call it. These are folks living with schizophrenia, schizoaffective disorder, bipolar disorder, or major depressive disorder, severe and recurrent. The majority of ACT clients experience some form of psychosis. But it's not just about the diagnosis. Plenty of people live with these diagnoses and do just fine. Along with these diagnoses, the person must have functional deficits in 2 or more areas. So those areas are vocational or educational. So perhaps because of their symptoms, they're not able to hold a job, or maybe they're able to hold a job, but they can only work 10 or 15 hours a week. So we know that's not enough to support yourself. So they might need some extra support in that. Or financial, some folks have difficult time managing money, social. So people with ACT clients typically have a hard time engaging with people or forming relationships. So we can support them with that. Or family, a lot of folks, by the time they make it to an ACT team, they're estranged for their family, or their family just doesn't know what to do next. Basic daily living skills is another one of those areas. So perhaps someone needs help, needs prompting to get up in the morning and take a shower every day. Or maybe they need help grocery shopping or planning meals or making their own meals. Housing is another big area. And then community or legal. For some reason, ACT clients find themselves with misdemeanors just for kind of piddly little things. Or then health and medical. So a lot of ACT clients also have complicated medical histories. So ACT teams can also help support them in that. Now remember, ACT clients don't necessarily have to have deficits in all of these areas. It's just 2 or more. Next slide, please. So here are the various roles that are required for ACT team. And this part is really exciting for us who have done ACT teams for a while. Each ACT role will receive evidence-based training and will receive ongoing coaching and mentoring. And this will look different for each of these roles. Now, why is this exciting, you might ask? Well, here at the state, using the various roles to their full capability has always been a struggle for us, and we've never really been able to do it. We are excited to be able to strengthen each role on the community ACT teams to lead to better outcomes for clients. For example, in Idaho, we really haven't been able to utilize the employment specialist roles. Rather, we've relied heavily on vocational rehab. The employment specialist will actually do similar work that VR provided, but it will be more expedited and it will be linked to the person's treatment. It'll be focused on the prime time for clients to get the vocational support rather than when they can get into VR. Next slide, please. So I want to talk a little bit about the history of ACT in Idaho. It's important to know where we've been and where we're going with it. Historically in Idaho, the majority of ACT services were provided by the Department of Health and Welfare state employees. This meant that the number of ACT clients we could serve was limited to the number of positions that we had, which has never come close to hitting the need for ACT services. We have hated to watch people who would benefit from ACT services go through that revolving door of hospitals and jails just because they weren't able to get the intensive services that they needed. Unfortunately, community agencies really haven't been able to provide ACT services due to how it's been reimbursed by Medicaid. I've talked to, owners of agencies that would say, yes, I'd love to have an ACT team, but it's not feasible. We can't get paid for it. I think that there is one community ACT team in the entire state, and that's up in Coeur d'Alene. At least it's the only one that I'm aware of. So we are really excited to be able to finally offer support to match community agencies' willingness to provide ACT services. ACT is becoming a Medicaid reimbursable service, and it will be accessible to all those who need it, not just those who have Medicaid, but this is thanks to our new Idaho Behavioral Health Plan and our contract with Magellan. Next slide, please. So let's talk about the Center of Excellence. The Center of Excellence is a brand new program and is unlike anything any of us have experienced within the state of Idaho. This is a big change in an effort to improve the behavioral health system in Idaho. Excitedly, our ACT Mental Health Court Center of Excellence team, which I'm a part of, has over 150 years of combined experience delivering ACT services in Idaho. We are the team that will be helping agencies navigate how to successfully implement ACT. We will help these teams develop their knowledge to the ACT level so that they can provide high-intensity outpatient services that are so desperately needed. Now, training is a big piece of the COE, and the training we will be offering will be free, and it will have CEUs attached. Now, I don't know if any of you here are in fields that require CEUs, but if you are, I'm sure you can appreciate how important free CEUs are. We'll also be providing coaching and mentoring on a few different levels. Coaching to the specific roles that I showed you just a minute ago, and then coaching to an entire team, as well as connecting all of the ACT programs together throughout the state for monthly coaching calls. After implementation, there will be opportunities for ongoing training, coaching, and mentoring. Next slide, please. So this has just been a high-level overview of ACT services and an initial look of what it will look like to work with the COE. You know, this is really a dream come true for most of us, to help provide services in a way that we at the state never could, but we always wanted to. I know that I can speak on behalf of the ACT COE team that we are dedicated to creating a new experience for community agencies and, more importantly, for our clients. So that is the end of my presentation. I want to thank you for allowing me to speak with you today. If anybody has any questions, I'd be happy to try to answer them.
I think the only question I have is the Magellan contract won't really increase the number of psychiatrists or mental health nurses or the number of people we have working with our individuals with behavioral health. And so is there other ways that the state is maybe trying to fill that need? Because it just seems like it's a limiting factor to do everything you want to do with ACT or the Center of Excellence. It seems like if we don't have the counselors or the physicians, I don't know how you're going to be successful.
Well, attracting psychiatric professionals is a challenge in Idaho. That's for sure. I mean, it has been expanded. When I first started in ACT, gosh, 15 or so years ago, it was just psychiatrists that we worked with. And now it's been expanded to psychiatric nurse practitioners and physician's assistants.
Mm-hmm.
I don't know if Magellan's going to be able to attract more providers. The plan is for them to be able to stand up an ACT team to begin with, at least one ACT team in each of the regions, each of the 7 regions. And hopefully, especially in the areas like Boise, where there's more population, they'll be able to work with more than just one agency to stand up multiple teams. Mm-hmm. Which is part of the problem we always had. We were always limited. I know I worked in the Boise office, and we were always limited based on our staff to 50 or 60 ACT clients. And practicing ACT to the model, an ACT team can be 100 people. So, hopefully Magellan will be able to stand up more ACT teams than what we were able to provide through the state.
Is there any estimates on how many people Idaho needs to try to be serving based on diagnoses?
I'm sorry, I don't think I understand the question.
I'm just curious how many people in the state of Idaho need your services?
That's a really good question. I don't have the answer to that. More than what we've been able to serve, I can tell you that. I'm sorry, I don't know what the numbers are. I can check on that. I don't know who has that type of statistic.
There is another question in the chat from Kathy Dawes. She says there is a current bill in the legislature that proposes work requirements for Medicaid recipients. Currently, what percent of recipients are already working, and what effect will such a requirement have on your services? Thank you, Kathy.
Well, there's always been a requirement attached to self-reliance services that individuals work a certain amount of hours, or that they be seeking employment. There are waivers to that, if people get, certification from their doctor saying they're not able to work, people are still being able to receive coverage. Sometimes those requirements can be devastating for our folks though, because some people aren't able to work, or they're not able to work the amount of hours that a lot of these other systems want them to. I don't know that I answered the question.
It looks like Joyce Lyons is saying that 1 to 2% of the general population. So if Idaho has 1,900,000 people, is that what you're thinking, Joyce?
Yeah, that's what, when you learn the DSM-5 and all, and the TR now, what you learn is that serious and persistent mental illness, which Christina and Carla both talked about, which serves ACT services. If you read the stuff that comes from the APA, that type of illness usually only affects 1 to 2% of the general population.
But keep in mind, not all of not that entire number qualifies for ACT services, because with ACT services, you have to have the diagnosis as well as the functional deficits.
Right.
I see.
And I don't know what the number is in terms of what percentage of those folks meet ACT level needs.
Yeah.
Marianne, I wanted to point out that I put in the chat a link to that waiver you were asking about. So that is a link that you can go to learn about that waiver. And I did confirm that you are free to share the slides with the folks on this call.
Okay, thank you.
You're welcome.
I guess I would like to ask a further question about Medicaid and Medicaid expansion. The legislature is saying that, it's costing so much more than they ever anticipated. And that's why this bill is being presented that could eventually eliminate Medicaid expansion entirely. And I guess I'm very concerned about this and how it will affect the ability for our state to serve those who have behavioral health needs. So if you can maybe address that a little bit more, I'd like to hear more.
Christina, you want to take this or you want me to?
Yeah, I don't have any information on this. So Carla, I'm not sure if you do, but I do not have any.
I have heard about that bill in the legislature, and you guys are well more versed in that than I am for sure. But I can tell you, if we lost Medicaid expansion, that would be devastating for our clients for sure. And I know that they say that it costs more, but I wonder what those numbers are, because if we can serve mentally ill people the way that we need to, if we can serve ACT clients and the number of ACT clients that we need to, which we've never been able to do in the state before because of the number of our positions, I can't imagine that that's going to cost more, because if you can't serve folks that have mental illness, they end up in the hospital more. They end up in jails more. It might come from a different pot of money, but I can't imagine that it actually costs more.
That is what I would really love for you to say to the legislators. I know for a fact that this bill is going to come up in a hearing in one of the committees, Health and Welfare, I imagine. And I've been watching several hearings lately and have watched the incredible testimonies given by people like you who know facts and know what you need and know what Idaho needs. And I would just like to encourage you to watch for that bill carefully and step up when they are asking for testimony. Thank you.
Thank you.
The other thing on that same line is that they have a new way of budgeting this year, and it looks like the health and welfare budget is kind of bumping up into some roadblocks. So I'm really concerned about the level of funding that health and welfare is going to receive from the legislature, because that'll affect, that trickle down effect of actually getting your program go live in July, ensuring that it works. So definitely have some concerns with the new way they're doing the budget.
Oh, believe me, we have concerns every year.
I see your question, Sharon. Are you referring to maybe like training, CEUs, things like that?
No, more like paying part of their college expenses or reimbursing colleges expenses, some way to increase the providers that we have in Idaho, as opposed to trying to recruit all of them.
That's a great question, and I have not heard that come up, but I will definitely take that back to see if there's any thoughts about that.
Thank you.
You're welcome.
I guess I could chime in one more time if I could. The bill number that I'm talking about is House Bill 419. So in case you wanted to read the bill and check up on it. Yeah.
Thank you, Kathy.
Well, we have about 5 more minutes. If there are any more questions, or before we get to our hard finish at 1 o'clock, I just want to thank Christina and Carla both for being so gracious to get online today with us and visit with us about what the plan is. And we'll be watching and supporting you in your work, and hopefully everything gets funded and rolled out without too many bugs. But I know you're going to be working hard, as you have been from now till July, to get this ready. So with that, I'm going to turn it over to Kylie, who's going to talk about our next League of Women Voters Speaker Series.
Hi, everyone. So I'll just share my screen with you. So next week, speaking of legislature issues that are ongoing, we're going to have our first in-person event of the year. This will be in the Arts Workshop of the 1912 Center here in Moscow. And the talk is called Book Ban Busters, Preserving the First Amendment. This will feature Heather Stout and Marianne Funk, who are both retired librarians from Lewiston and have co-founded the North Central Idaho Alliance. So I think this should be a really interesting talk. Next week, we're going to try to record it so we can get it up on YouTube as well for those who can't attend in person. But that's coming up next Wednesday, same time at noon, but in person.
Great. So this has been recorded today. Christina and Carla, if you want to go in and look at how things turned out today or share it with any of your other people that you work with, it'll be on the League of Women Voters of Moscow website, and it usually takes about 3 or 4 days to get it posted, but it'll be up there soon. So.
Great. Thank you so much. I really appreciate the opportunity, and it was a pleasure meeting all of you.
Thank you.